45-year-old female, 3-hour headache. No points for spotting this hemorrhage, pretty obvious, but the location is important, right? If we look on the contralateral side, caudate head, internal capsule, lentiform nucleus. So this looks like it's centered within one of those deep grey structures within the lentiform nucleus. So this is a classic site, the most common site for hypertensive hemorrhage. This has also got features that tell you it's a primary bleed as well. When you look at this, it's almost all bleed, isn't it? There's no edema around it, okay? For a lot of those processes, if it's secondary, the lesion underlying it will have caused edema. So if it was a tumour, there will have been edema around the tumour. If it was an infarct, there would have been edema from the infarct before it bled. So having very little edema around it is a sign that it's probably a primary hemorrhage. After 24 hours, there will be a lot of edema around this, so it's on the initial scan that you do. Okay, so that's good for primary bleed. It's not perfectly round. Anytime I see a perfectly round hemorrhage, it's suspicious that it's a hemorrhage into a metastasis, so a hemorrhagic metastasis. So it's not perfectly round, it's a little irregular in shape. The density is pretty uniform in this case, which is good. There's maybe one little area here that's a little bit hypodense compared to the rest. Variation in density often tells you that it's still bleeding. When it's actively spurting, that little bit of blood that comes out is hypodense, and then it takes a little bit of time to become dense, okay? So maybe most of this is pretty stable, maybe there's a little area that's still bleeding in this one. This has ruptured into the ventricle, probably into the frontal horn here, because we can see that beautiful example of the layering of blood in the occipital horn of that left lateral ventricle. So intraventricular extension is a poor prognostic sign because it's going to stop the hemorrhage from tamponading. It's going to continue to rupture into that ventricle. So basal ganglia, primary looking hemorrhage, not much edema around it, not too round, hypertensive hemorrhage, doesn't really need any further workup. Don't need to do a CT angiogram. Here's another patient. This is much larger hemorrhage, but again, it's centered in the lentiform nucleus. Here's the other one on the other side. Here it is. This one's much more irregular, isn't it? Much more variable in density. So it's probably much more likely that this is still increasing in size. Again, it's ruptured into the ventricle. And there's not much edema. There is edema around it, but relative to the size of the hematoma, the edema is a lot less. Okay, so it's again pretty good for a primary hypertensive hemorrhage. You don't need to do an angiogram, but if you do, you might spot this, which is some contrast blush into the hematoma. This is not a true aneurysm. This could be active bleeding or a pseudoaneurysm. So again, it's a poor prognostic sign. So we've thought, irregular shape, intraventricular extension, variable density, and an angiographic spot sign. They're poor prognostic signs for an intracerebral hemorrhage, suggest that it's likely to get bigger. And sure enough, this is the same patient and it's got a whole lot bigger. So those features may inform whether you're going on to doing further management versus palliation in these patients.